delighted to have Professor Kyoko Ono-Matsuri here today, where she'll be sharing with us her expertise and knowledge in pathologic myopia. Prof Kyoko is no stranger to us at all. She's a leading expert in the field of myopia, in particular, pathologic myopia and imaging modalities for myopia. She's currently a professor and chairperson at the Department of Ophthalmology and Visual Science at Tokyo Medical and Dental University. After graduating from Yokohama City University with a medical degree, she proceeded to pursue her PhD in Tokyo before doing a postdoctoral fellowship at the Wilmer Eye Institute at Johns Hopkins University. Some of us may be familiar with the International Photographic Classification of Myopic Maculopathy, which was established by Prof Kyoko and her team during her research. For all her excellent contributions to the field of ophthalmology, it comes as no surprise that Prof Kyoko is also a member of the prestigious Macular Society and the Retina Society. I'm excited to hear about what Prof Kyoko has to share with us today in terms of the advances in imaging techniques for myopia. For all our participants here today with the webinar, please kindly use our Q&A box to type in your questions so that we can address them at the end of the talk. So now, Professor Kyoko, here's over to you. The stage is yours.
Thank you very much. Thank you very much, Janice, for your kind introduction. And I'm very happy to have a chance to speak today. So I'd like to start my presentation.
Yes, please.
Yeah. Okay. Can you see now? Slideshow. Oh,
yes, we can.
Sorry, this is not a first slide. So I will change. Sorry. Okay. Can you see now my first slide?
Yes, we can.
Okay. Hi, everybody. Today I'd like to talk about pathologic myopia. The prevalence of myopia has been increasing worldwide, especially in East Asia. The right graph shows a prediction that by 2050, half of the entire population in the world will become myopic, and 10% of the world population will become highly myopic if the current trend continues. And most of myopic patients maintain good corrected vision. However, pathologic myopia is a major cause of blindness. This is a review article written by Dr. Tian Wang, and he showed that pathologic myopia was ranked as the second to the fifth most common cause of blindness in the 4 studies of white populations, and was the most common cause in the Chinese study as well as in the Japanese study. First, what is the definition of pathologic myopia? In a review paper by International Myopia Institute, or IMI, low and high myopia are defined according to the degree of myopia. In contrast, pathologic myopia is defined by its structural abnormalities. Pathologic myopia is defined as excessive axial elongation associated with myopia that leads to structural changes in the posterior segment of the eye, including posterior staphyloma, myopic maculopathy, and myopia-associated optic neuropathy. Fundus complications, which cause visual impairment in patients with pathologic myopia, include myopic maculopathy, myopic traction maculopathy, and glaucoma or optic nerve damage. And the cause of developing these above complications is posterior staphyloma. First, myopic maculopathy. And this is what Janice kindly introduced today. According to the Meta-PM study group, myopic maculopathy is classified into these 5 categories: 0, no maculopathy; 1, tessellated fundus; 2, diffuse atrophy; 3, patchy atrophy; and 4, macular atrophy. And macular atrophy is almost always neovascularization related. Other lesions like laca cracks and myopic neovascularization, which occur irrespective of the progression of these categories, were considered plus lesions. Then, what are OCT features of each lesion of myopic maculopathy? First, diffuse atrophy. This lesion is yellowish atrophy in the posterior fundus and is one of the common findings in pathologic myopia. This lesion is characterized by extreme thinning of the choroid in OCT images. As shown in this OCT image, almost the entire choroid disappears, besides sporadically remaining large choroidal vessels. So retina and sclera also thin, but the choroidal thinning is disproportionately more serious than retinal or scleral thinning. And diffuse atrophy starts from peripapillary area in childhood as peripapillary diffuse atrophy, or PDCA, which later progresses to macular diffuse atrophy, or MDCA. PDCA is characterized by an abrupt thinning of the peripapillary choroid. The transition from relatively normal choroid around the fovea to almost absent choroid is sudden. And because it's not a generalized thinning of the choroid, circulatory disturbance may not be a cause. But anyway, although the area is different, peripapillary diffuse and macular diffuse both are characterized by the extreme thinning of the choroid. Actually, a progression from tessellated fundus to diffuse atrophy can be explained by choroidal attenuation based on OCT studies. Extreme choroidal thinning starts from peripapillary area as peripapillary diffuse atrophy, and later it extends to the fovea as macular diffuse atrophy. Different from diffuse atrophy, patchy atrophy is a well-defined and whitish lesion. It often develops in the area of macular diffuse atrophy. This slide shows the mean subfoveal choroidal thickness in each lesion of myopic maculopathy. The mean subfoveal choroid decreased progressively as the severity of myopic maculopathy from no maculopathy to tessellated PDCA up to macular diffuse atrophy, or MDCA. However, there was no further thinning after macular diffuse atrophy, maybe because choroidal thickness hits bottom in macular diffuse atrophy. Then what is patchy atrophy? OCT shows that it's not simply an atrophy, but it's Bruch's membrane hole. In this patient, the right fundus shows 3 lesions of patchy atrophy, shown by white arrows. In OCT images, the RPE, the end of retinal pigment epithelium is shown by arrows. So the retinal pigment epithelium is defected in the area with patchy atrophy, and increased light penetration to deeper tissues is observed in the area without pigment epithelium. In addition, the end of Bruch's membrane is shown by arrowheads, black arrowheads. And as you can see, in most area of patchy atrophy, both retinal pigment epithelium and Bruch's membrane are defected. This feature of lacking Bruch's membrane is different from geographic atrophy in AMD. In this case, the left fundus shows an area of patchy atrophy lower to the fovea, and horizontal OCT scan across this area shows the end of RPE indicated by arrows, and an increased light penetrance is observed in the area defective of RPE. And the remnants of the Bruch's membrane observed near the edge of Bruch's membrane defect are jagged, as shown by arrowheads. And in an area without Bruch's membrane, almost the entire choroid is missing, and the inner retina is in direct contact with the sclera. Actually, patchy atrophy develops away from the central fovea, and it does not usually secondarily involve the fovea during enlargement. These cases, the top case and the bottom case, had multiple areas of patchy atrophy at baseline. The lesions enlarge with time. However, they do not enlarge to the direction to the fovea. The fovea is still spared in 10 years. Although why this happens is uncertain, foveal Bruch's membrane may be stronger and protected, or there may be some directional force for enlargement of Bruch's membrane holes. So in the progression from diffuse atrophy to patchy atrophy, there was no further choroidal thinning. So this progression is not due to a progressive choroidal thinning, but is due to a new formation of Bruch's membrane holes. But it is also possible that extremely thin choroid in macular diffuse atrophy may be a prerequisite to developing Bruch's membrane holes by making Bruch's membrane more fragile. Next, myopic traction maculopathy. Myopic macular retinoschisis, or MRS, was first reported by Dr. Kish's group and is found in 9 to 34% of highly myopic eyes. This condition has been reported to progress to serious complications like macular whole retinal detachment in the natural course. Usefulness of vitrectomy has been reported by many investigators. We consider that the cause and the prognosis are different according to the distribution of retinoschisis. So the eyes were classified into 4 groups based on the size and the location of retinoschisis. S1, extrafoveal retinoschisis. In many cases, retinoschisis starts along retinal artery and around the optic disc. And S2 is foveal only. S3 is both S1 and S2, but does not cover entire macula. And S4 is entire macula. So these are representative OCT images in each category. S0 is no retinoschisis. S1, as shown in this OCT image, extrafoveal. And S2 is foveal only retinoschisis. And S3 is a combination of S1 and S2. And S4 is entire macula in 6 millimeter OCT image. But now we have a wide field OCT with Canon at this time, scan width of 23 millimeters and 5 millimeters depth. So we now use this ultra wide field OCT for retinoschisis too. And by using ultra wide field OCT, we have reclassified retinoschisis. Actually, these are wide field OCT images, and S0 to S4 are the same as the previous classification. But with wide field OCT, S4, we can see the entire extent of S4 retinoschisis with wide field OCT. And we added two conditions. One is S4 large D, which is the entire macular retinoschisis, but the fovea is attached because of the dome-shaped macula. And another S5 small d is diffuse retinoschisis, even beyond the range of wide field OCT. And surgical indication of retinoschisis is still controversial. Once foveal retinal detachment develops, the visual impairment often remains, although the vision improves to some extent after surgery. So we have carefully analyzed the process of developing foveal retinal detachment from retinoschisis alone by examining the series of OCT images of the eyes which developed foveal detachment during a follow-up. And we observed these 4 stages. At stage 1, a slight elevation of outer retinal tissue is seen. And at stage 2, outer lamellar hole develops within the elevated retinal tissue. At stage 3 and 4, the area of the height of detachment keep increasing. And once the outer lamellar hole develops, which is stage 2, foveal detachment occurs relatively soon. So we experience that when the height of retinoschisis becomes the same as the retinal thickness, mechanical tension loaded onto the outer retina reaches the maximum. So, and soon after that, after outer lamellar hole develops, So these days, we consider surgery for patients with retinoschisis alone when the retinoschisis is as high as the retinal thickness. In other words, when the retinal thickness becomes double, we consider surgery. And before going to more detail of retinoschisis, I would like to go over posterior staphyloma because it's closely related to the development of traction maculopathy. Actually, Curtin emphasized the importance of staphyloma in defining pathologic myopia 40 years ago. Based on many of his observations, he suggested that it is apparent that refractions and axial lengths are unreliable indicators of even the very diagnosis of physiologic or pathologic myopia. The morphology of the staphyloma would be a much more reliable basis for genetic studies. So when I have been studying, analyzing, examining pathologic myopia for many, many years. But when we keep studying pathologic myopia, we, like Dr. Curtin, we reach posterior staphyloma. And Curtin classified staphylomas into these 10 different patterns. The first 5 were simple staphylomas, and the remaining 5 are compound staphylomas. Compound staphylomas are characterized by additional irregularities within an area of staphyloma. But first, what is the definition of staphyloma? In the textbook of pathologic myopia, Dr. Spade clearly defined the staphyloma as an outpouching of the wall of the eye that has a radius of less than the surrounding curvature of the wall of the eye. So the left one is the normal eye. Axial length elongation mainly occurs in the equatorial region, and that does not induce an alteration in the curvature of the posterior part of the eye. And the middle one, middle eye, would have axial myopia, but no staphyloma. But when the second curvature develops in the posterior portion of the eye, and this second curvature has a shorter radius of the curvature than the surrounding wall, this second curve is due to a staphyloma. And sometimes a generalized bowing of scleral curvature due to axial elongation is confused with staphyloma. But staphyloma is a protrusion of a limited area of the posterior fundus, so the detection of staphyloma edges is important for diagnosing staphyloma. And when I joined the high myopia clinic a long time ago, I thought that staphyloma formation was just a continuum of axial elongation. Emmetropic eyes become myopic by axial elongation. And this axial elongation mainly occurs in the equator of the eye. I thought that posterior staphyloma later develops when highly myopic patients get older, and this staphyloma may cause further increase of axial length. However, sometimes when I took angiograms in the far peripheral fundus in the eyes with deep staphyloma, I had to add more plus lenses to focus these areas than emmetropic eyes. So, and in addition, in 3D MRI image, in eyes with very deep staphyloma, sometimes surrounding curvature flattens, more flattens than normal curvature. So it's not a continuum of axial elongation. So I often show this picture. This is a rice cake, and it uniformly swells first when we bake. But once the central part pops out, the surrounding part becomes flattened. So the similar thing might happen to staphyloma development. Staphyloma formation is not a continuum of axial elongation, but a drastic change of the entire shape of the eye. But I thought that how could I prove this hypothesis? To solve this, I need to visualize the entire shape of the eye. That is why we developed 3D MRI. We used T2 wave MRI, which revealed the fluid filled chamber of the eye. Volume renderings were generated, and the tissues outside the globe were carefully removed. And 3D MRI enables to analyze the entire shape of the eye in three-dimensional way from any angle. Emmetropic eyes are spherical, but the eyes with pathologic myopia are not simply elongated, but severely deformed. The most common type of staphyloma is wide macular staphyloma or Curtin's type 1 staphyloma. 3D MRI images show a protrusion of wide area of the posterior segment in the images viewed from nasally, inferiorly, and from the back. And the temporal border and the upper border tend to be more abrupt, and there is a notch along the upper and temporal border of staphyloma. The protrusion is horizontally wide in the images from the back. And the most protruded point exists along the central axis in half of the cases, but lower to the central axis in the other half. So for some reasons, the lower part of the eye tends to expand more than the upper part. But in general, wide staphylomas tend to be deep and narrow staphylomas tend to shallow. And using 3D MRI, Dr. Huang conducted this very important study. They analyzed highly myopic eyes with staphyloma, and 3D MRI scans were acquired while subjects gazed in different directions. Significant gaze-induced globe deformation was noted in all gazes, but a reversible, instantaneous deformation occurred only in down gaze, which is consistent with studies supporting the association of environmental factors such as near work with myopia development and progression. 3D MRI is a powerful tool to analyze staphylomas because staphyloma usually covers the wide area. And 3D MRI is the only method enabling to visualize the entire shape of the eye. But it's still difficult to routinely perform 3D MRI as a screening. So we now use ultra-wide field OCT, which is now available in Europe, in Japan. I show some representative cases with staphyloma. In the optus image, the upper edge of staphyloma is seen. And 3D MRI image viewed from the inferior and from the nasal side show a wide macular staphyloma. In B-scan or wide field OCT, the staphylomatous region shows a posterior displacement of the sclera. Staphyloma edge shows consistent features with gradual thinning of the choroid from the periphery toward the staphyloma edge and a gradual re-thickening toward the posterior pole. In parallel, scleral inward protrusion is seen at the edge. 3D OCT movie clearly visualizes the entire shape of staphyloma. Different from 3D MRI, spatial relationship between staphyloma and the optic disc, macula, and retinal vessels is clearly seen. This facilitates the understanding how visually important tissues are damaged by eye deformity due to staphylomas. In the second case, in a horizontal scan by wide field OCT, the staphylomatous region shows a posterior displacement of the sclera. And the staphyloma edge shows consistent features with the previous case, that is gradual thinning and a gradual re-thickening of the choroid and inward protrusion of the sclera. And 3D OCT movie clearly visualized the entire shape of wide staphyloma. And you can also see spatial relationship between staphyloma and optic disc and macula. This third patient has inferior staphyloma. In optus image and autofluorescent image, upper edge of staphyloma shows deep pigmentation, and you can see choroidal folds spreading from the upper staphyloma edge. In a vertical scan of wide field OCT, the staphylomatous region shows a posterior displacement of the sclera. Again, staphyloma edge shows consistent features. 3D OCT movie clearly visualizes the entire shape of inferior staphyloma. And you can see even chorioretinal folds emanating from the staphyloma edge because of the high resolution of the image. In this patient, you can see 3 staphylomas, one around the optic nerve and other upper and lower to the fovea. So the types of staphylomas may be more complicated than previously thought. So we then compared the detectability of staphylomas between wide field OCT and 3D MRI in the patients who received both examinations. And the results showed that kappa was 0.609, and the strength of agreement is considered to be good. So this suggests that wide field OCT can replace 3D MRI for detection of staphylomas. Then I go back to retinoschisis. Wide field OCT visualizes a spatial relationship between staphylomas and myopic fundus lesions, especially retinoschisis. In this patient, this is staphyloma edge. And as you can see, inner and outer retinoschisis is restricted to the staphylomatous area. So when retinoschisis occurs in eyes with staphyloma, retinoschisis does not go beyond the staphyloma edge. In this patient as well, these are staphyloma edges. Like the previous case, outer retinoschisis is restricted within the staphylomatous area and does not go beyond the edges. In contrast, in the eyes without evident staphyloma, diffuse retinoschisis is seen. In this patient, choroidal thickness is uniform and no OCT features showing staphyloma edges are seen. Outer retinoschisis is seen only in the macula. However, inner retinoschisis is widespread toward the periphery. In the vertical scan, widespread inner retinoschisis is well observed, and within the space of inner schisis, sporadically remaining retinal vessels are observed to be actually floating. And in 3D OCT movie, you can see a detached ILM, and we can also dive under the ILM and see how retinal vessels are lifted like grasshopper legs. And we can also see many columnar structures connecting the ILM and retinal vessels. So the view, which is not possible with our own eyes, is possible with this device. And when retinoschisis occurs in eyes without staphylomas, vitreous may possibly play a major role. And vitreous-retinal surgeons often encounter residual vitreous cortex over the retina in highly myopic eyes. However, imaging vitreous is always difficult. And very recently, Dr. Spade has established a new technology called boosted OCT to visualize the vitreous. It is in his boosted OCT, 3D structures of vitreous gels and cisterns are very beautifully seen. I think this novel technology will reveal many unknown mysteries of vitreous. Instead of boosted OCT, we have used 2 methods to visualize the vitreous: ultra-wide field OCT B-scan and AI-driven 3D OCT with Triton. And before showing the results of highly myopic vitreous, I will briefly show you our data on vitreous structures in normal eyes with 2 methods. This slide shows the ultra-wide field OCT image of a 57-year-old man with mild myopia. You can see pre-cortical pocket, cloac canal, and many cisterns. In a vertical section, the pocket joins with other cisterns and go farther upward. Ultra-wide field OCT image visualizes the detailed structures of the vitreous in a wide and deep range. However, it's still difficult to imagine how 3D figure of the vitreous is. So in order to visualize the vitreous, we established 3D reconstruction of the vitreous fluid space. This slide shows 3D segmentation workflow. In each plane, a deep learning model is trained to segment the vitreous fluid space in the entire OCT volume. Next, information from all these three planes is combined for further noise reduction and optimization. This movie shows cloak, canal, and pocket, and then they merge to form a large space. In an oblique angle, you can see some fluid space above the retinal vessels. This side view shows that the pocket continues upward. Premacular pocket looks like a hand scooping the water. This patient's other eye has peripapillary vitreous detachment. In a close observations, structures like pocket, cloak canal, and cisterns are visible within the detached vitreous. Although lifted anteriorly, these structures appear similar to his other eye. In the vertical section, pocket and cistern almost keep their shape within the detached vitreous, and they are simply lifted. In this 33-year-old woman with mild myopia, you can see a beautiful structure of vitreous in a wide and deep range. Cisterns are larger near the macula and more linear in the periphery, and some cisterns run in parallel. In a vertical section, pocket continues upward as a wide channel, and other cisterns are seen to run in parallel. This is her other eye. Again, you can clearly see fluid space. Cisterns are larger near the macula and more linear in the periphery. A vertical section also shows that pocket continues upward. Actually, vitreous looks strikingly similar between both eyes in most patients. In Anfa's view, cloak canal and pocket appear separately, and then they merge and it becomes widespread farther anteriorly. In this movie, a pocket is observed like a hand scooping water. A large channel running upward from the pocket is clearly seen. But some patients have very complicated vitreous structure. Then, how does the vitreous appear in highly myopic eyes in OCT images? Because of vitreous liquefaction, it is difficult to observe details of the vitreous cell in highly myopic eyes. However, the posterior front vitreous surface can be clearly seen. There are two main features of a highly myopic vitreous. They are atypical PVDs and vitreous adhesion to retinal blood vessels. Among the different types of atypical PVDs, asymmetrical PVD is the most common, and the location of the asymmetrical PVD corresponds to the area where the sclera protrudes most posteriorly. Additional PVD arrows are slightly displaced, but additional PVD is seen, so suggesting multi-layered PVD. Multiple vitreous adhesions to retinal vessels are another feature. In this patient with macular retinoschisis, the posterior vitreous surface appears thickened, and it is adherent at multiple points, and these points are actually retinal vessels. And a close observation shows additional PVD here, suggesting multi-layered PVD. Multiple vitreous adhesion to retinal vessels are clearly seen in this movie. It shows the starfish-shaped figure of the partial PVD. In this case, the vitreous adhesion to retinal vessels is so tight that extremely stretched vitreous strands can be seen. Such strong adhesion to retinal vessels may underlie the development of myopic traction maculopathy. In this case, with myopic retinoschisis, the posterior vitreous is thickened, and there is a single strand connecting the posterior vitreous to a retinal vessel. But in this 3D movie, you can see numerous strands connecting the posterior vitreous surface and retinal vessels. This image shows how strong the vitreous adhesion to retinal vessels is in pathologic myopia. Wide field OCT shows that the adhesion to retinal vessels may play more important role for development of retinoschisis than adhesion to the fovea. For example, in this patient with retinoschisis, OCT shows that the posterior vitreous is detached within the area of staphyloma, In addition, the vitreous adhesion to the fovea is seen. So only with this image, we may think that the retinoschisis of this patient is caused by foveal traction. But an adjacent OCT image shows that a posterior vitreous is detached, but as shown by arrows, 3 retinal vessels are lifted, and outer retinoschisis is more severe around these vessels compared to the foveal area. In addition, inner and middle schisis are seen around the retinal vessels. And adjacent OCT section shows that the posterior vitreous is adherent to the inner retinal surface at the site of these retinal vessels. At the site of adhesion, posterior vitreous is seen with relatively higher reflectivity compared to other areas. So these multiple images show that the retinoschisis of this patient probably started around retinal vessels, and the vitreous adhesion to retinal vessels may be an important cause. And then retinoschisis starting around the retinal vessels spread to the fovea secondarily. And these observations are possible by visualizing a wide area of the fundus beyond the macular area. Wide and deep observation of vitreous clearly shows abnormal vitreous strands. This patient has a dome-shaped macula by conventional OCT. In close observations, we can see unusual strands of the vitreous, but the images are flipped over and only a limited area of the vitreous can be seen. But this is an ultra-wide field OCT image of this patient. Several unusual vitreous strands can be seen to rise from the retina and extend anteriorly. These strands appear to be attached to the retinal vessels. This is an adjacent section. Actually, these strands can be seen to be moving in dynamic observations. In 3D movie, you can see how long these strands extend from the retina anteriorly. It can easily imagine that the movement of such thick and long strands could cause severe traction on the retina during eye movements. So for the sake of time, I'll skip this. And with ultra-wide field OCT, actually dynamic observation of the vitreous is also possible. This is important because vitreous is a moving tissue. So when vitreous becomes a tractional force, it can act as a moving mass. In this patient, you can see an oddly shaped, partially detached vitreous. A close observation shows that vitreous is still attached to the lower part of the optic nerve. And dynamic observation of this patient shows a wave-like motion of the posterior vitreous coordinated with the eye movements. The movements are less obvious near the optic nerve because the vitreous is still attached there. Similar wave-like motion of the vitreous can also be seen in this patient with an asymmetrical PVD. The vitreous is still attached to the optic nerve head. In this patient, the posterior vitreous is attached to peripapillary area, and vitreous shows rapid displacement, such as a whiplash movement. So although movement is various among patients, such vitreous motions can exert mechanical traction on the attachment site, often on the optic nerve head and the retinal vessels. In the movie of this patient, you can see 2 exact sites where the vitreous is tightly attached. It's a temporal part edge of the optic nerve. So I would like to go back to Curtin's words here. Curtin emphasized the importance of staphyloma 40 years ago. And the main role of sclera is to protect central nervous tissue from mechanical insult. And both sclera and skull bone contain nerve tissue in them. However, compared to a skull bone, the sclera is a fibrous tissue and more fragile. And it's easily imagined that the deformity of the sclera can mechanically damage the central nervous tissue inside. We believe that the integral feature of pathologic myopia lies in the eye deformity, and pathologic myopia may be a representative disorder developing eye deformity in an acquired fashion. To prevent the blindness due to pathologic myopia, therapies targeting staphylomas may be an ideal approach. Chen and colleagues recently conducted meta-analysis of 11 articles reporting the effect of posterior scleral reinforcement. The outcome was an effect on axial length and not staphyloma formation, but it is interesting to maybe try. And further therapies targeting staphyloma have been investigated, including scleral collagen cross-linking and scleral regeneration. We have also reported that autologous transplantation of skin-derived fibroblasts along the outer surface of the sclera thickened the posterior sclera by producing collagen in situ, and the transplanted animals showed less degree of myopia in experimental myopia models. So preventing and treating staphyloma is an expected therapy for pathologic myopia before vision-threatening complications occur. Finally, although staphyloma is really important for pathologic myopia, it's not certain at around what age staphylomas develop. To solve this question, we recently analyzed longitudinal change of scleral curvature in highly myopic children and adults. And this is an 88-year-old girl with axial length of 26 millimeters. At baseline, the inner scleral curvature is inclined toward the optic disc and no staphyloma edge is seen. And 3 years later, axial length has increased by 1 millimeter, and scleral inward protrusion, suggesting a staphyloma edge, is formed nasal to the optic disc. And the macular sclera bows more posteriorly, and the curvature has changed to symmetrical around the fovea. The location of staphyloma edge also changes with time. In this 11-year-old girl, staphyloma edge is seen nasal to the optic disc at baseline. And 4 years later, nasal staphyloma edge has become farther away from the optic disc. And in parallel, the posterior bowing of the sclera has increased, accompanying with scleral curvature changes from symmetrical around the fovea to asymmetrical around the fovea. So fovea is now on the slope, and its deepest point of the sclera shifted temporal to the fovea. And this is an 11-year-old girl. Mild staphyloma edge is already seen at baseline. And 4 years later, in addition to pre-existing edge, a new staphyloma edge is formed temporal to the optic disc. So these data show that staphylomas may develop at a much younger age than we previously thought. And children who become pathologic myopia may already be different from usual myopes in their childhood. So early intervention may be necessary to prevent the development and progression of staphylomas. So in summary, myopic maculopathy is characterized by extreme thinning of the choroid and Bruch's membrane defects. Posterior staphyloma is an important feature to differentiate pathologic myopia from physiologic myopia. 3D MRI and ultra-wide field OCT are useful to detect the entire extent of staphylomas. In addition to staphylomas, abnormal vitreous adhesion to retinal vessels may be one cause of retinoschisis. Therapies targeting staphylomas before developing blinding complications are expected. So thank you very much for your attention. Thank you very much for inviting me today.
Hi, thank you so much, Prof Kyoko, for the insightful talk you shared with us today. I see that we have some new joiners to the webinar, so perhaps I'll introduce myself again. My name is Janice, and I'm a pediatric ophthalmologist and strabismus surgeon at the National University Hospital of Singapore. And joining us today as a panelist is Dr. Sun Chen-Sin, whose interest in myopia research had brought him to Japan a few years ago. I'm very happy to have Dr. Sun as part of the team I work with at NUH, and I'm glad he could join us for the webinar today. We welcome all participants to kindly post your questions within the Q&A box, and we can answer them accordingly. I hope we refrain from asking any personal questions, but target the questions to Professor Kyoko's talk today, and we can discuss this further. So before we open up to everyone, perhaps I could ask a question first. So Prof Kyoko, I think it is amazing to see the whole array of imaging modalities that are available to assess the choroid, the retina, and posterior vitreous. So could I just ask, for every patient that has high myopia in your clinic, do you do a whole array of imaging for every single patient? Or do you only do it if there's evidence of posterior staphyloma or evidence of myopic maculopathy? That's my first question. And if you do have a protocol for your imaging, is it a full spectrum for every single patient, or is it like a targeted selective panel that you use based on what you see clinically?
Thank you so much. Actually, in our high myopia clinic, especially at the initial visit, we conduct a whole array of all examinations, including a wide field OCT, but 3D MRI. We don't do it usually because it's costly. And so including OCT and visual field and even angiograms, fluorescent angiogram and indocyanine green angiograms and axial length, of course. So autofluorescence, wide field fundus images, everything at baseline. And after that, maybe fundus photos and OCTs and autofluorescence are taken on every visit. But usually visual field and angiograms are visual field is every year, once a year, and angiograms are when necessary. But we do all examinations at baseline. I think it is very important because later when some lesions develop, we can know that what happened before that lesion occurred. So we think performing all examinations at baseline is very important.
Okay, great. Thank you. Thank you so much for Prof Kyoko. I'll be interested to see your like full protocol of imaging, and we can probably like exchange thoughts on that later on.
Yes.
I have other questions. You mentioned about targeting the posterior staphyloma with like posterior reinforcement, and a couple of the studies that did that. Did the results from the study correlate with better visual outcomes?
Scleral reinforcement. I'm not sure. Their outcome is axial length elongation, and actually, the vision is not severely impaired in many lesions of maculopathy, and because even in severe diffuse atrophy, the vision is often maintained as 0.7 or a bit relatively good. So unless 3 lesions occur, vision is relatively maintained. And these 3 lesions is macular neovascularization and macular neovascularization related to macular atrophy, or traction maculopathy, or glaucoma, or optic nerve damage. These 3 lesions. And unless without these 3 lesions, the vision is relatively well maintained.
Okay, great. Thank you so much. Dr. Sun, do you have anything to share with us or ask Prof Kyoko, please?
Yes, so as Janice was mentioning, I was very impressed by Prof Kyoko's team. On Fridays, they have the entire clinic dedicated to pathological myopia, and I see the team of doctors, residents collecting data for every patient. So I think that is something that we should strive to achieve for our patients with high myopia, to follow them up for and monitor their progression. I have a question regarding the imaging modality. So we have the Optos Silverstone that has ultra wide field OCT available as well. Have you any experience using the Optos Silverstone? Is that useful as the Canon device?
Yeah, I think Silverstone is very useful, but we don't have one because it's too expensive, so we cannot afford that yet. But mainly posterior fundus lesions are paid a lot of attention, but the peripheral fundus is also stretched because of the axial elongation, and because peripheral lesions are not examined thoroughly, I think the use of Silverstone may reveal new findings there. So I'm really interested in that, but I don't have any experience.
I see. The downside of the Silverstone is there is no quantitative analysis that is available to the traditional macular OCT like the spectralis, and there's no follow-up function to track changes. So I think this makes the follow-up not so easy to monitor in terms of progression. So I wonder if that is available for the Canon system. Does it have a quantitative analysis of the changes of structures?
Yeah, actually, that part is difficult. And the first Canon wide field OCT, it's wide, but still narrow compared to Silverstone. So the area which we can observe is still limited. And even in Canon OCT images, posterior part is okay, but in the peripheral fundus, the image is somewhat distorted. So we cannot measure the actual retinal thickness or choroidal thickness. So the quantitative study is still difficult.
I see. And being a pediatric ophthalmologist myself and Janice, I'm very interested on the case that you showed, the 11-year-old girl.
Yeah.
The axial length is 26.5, and 4 years later, it actually didn't change that much.
Yeah, that's right, 26.7.
But you see that the shape of the retina structurally changed so much. Distortion.
Yes.
So I think this is something that we don't usually pay attention to.
Yes.
I think from now on, we should really look at these changes on the OCT. And perhaps these patients need a closer follow-up and more stringent control on their myopia progression.
Yeah, thank you very much for your comments. Yes, as you mentioned, the axial length does not change much. And even when I compare fundus photos at baseline sometime later, I didn't recognize much changes compared to OCT images. So the scleral curvature change occurs even in eyes whose axial length does not elongate much, increase much. So yeah, this time we first recognize this by using a wide field OCT, but it is interesting. And we also examine the later age group, like adolescents, young adults, and middle age, but such dramatic curvature change in a short period is characteristic to children. In later ages, we don't see those dramatic changes.
Thank you very much.
Thank you.
There are some questions on the Q&A box. Janice, you want to pick a few?
Yes. So, all right, we're getting some questions on the Q&A box, so let's get to them. I think the first question was noting myopia is increasing nowadays, and investigation and diagnosis and treatment may be evidenced advanced nowadays. So how can we know if there's any prevention ways upfront for us to get myopia? I think this is actually both Chensin and I are pediatric ophthalmologists, and we also have a very robust pediatric refractive service in NUH. We, of course, as we all know, the recent WSPOS consensus has come out. It's available online. WSPOS meaning the World Society of Pediatric Ophthalmology and Strabismus. The consensus on myopia prevention and treatment strategies are all out there. There is you as a primary eye care practitioner, if you're asking as a primary eye care practitioner, then there is a document just for ophthalmologists and primary eye care practitioners, as well as another document for patients and their parents. So I think you can refer to that, but in summary, you know that, preventive measures such as, more outdoor time, having good near work habits, not exactly just limiting screen time, but having good near work habits are very important. And therefore, I think that is something that we can strive towards if you're a parent or if you are caring for children. Would you agree with that, Prof Kyoko?
Yes, of course. Thank you very much for answering that. Yes, perfect answer. Thank you.
So I think there's this area, one of our participants asked that patients with posterior staphyloma, but doesn't affect the macula, the visual acuity can still be maintained. I think that's what Prof Kyoko mentioned earlier, that unless you have glaucoma, retractional myopic maculopathy, generally, just with a posterior staphyloma, they usually would have a good vision.
Yes, that's right. Thank you.
Yeah. So I think we answered the question about effective prevention ways from getting any myopia. Please do. I've just answered them earlier. I don't know about you, Chen-Sin, but do you think that EMSLA chart is a good screening tool for complications in children with myopia? I personally don't think so.
Yeah.
No.
It's
No.
not I don't think EMSLA chart, always vision is much better. Always doing a good refraction, cycle refraction, if it's age appropriate, is definitely important. Visual acuity and checking vision by age appropriate methods are still the way to go forward. So I don't think EMSLA chart is a good idea, right, Prof Kyoko?
Me neither.
Yeah. Okay. Any studies show that myopia is genetically inherited? If yes, dominant or recessive genes expression. I think we all know that myopia has a familial predominance, right? Preponderance, basically. So, we know that if you have one myopic parent, your odds ratio of getting myopia is about 1.5 times. If you have two myopic parents, it's about 2.7 times. If you have two myopic parents who have children who were myopic when they were very young, then it's about 3.5 times, I think so. And so, but if you're talking about whether it's autosomal dominant, autosomal recessive, I don't think it's as clear-cut as that, right? Prof Kyoko, do you have anything?
Yeah, that's right. That's right. Yes, yes. But interestingly, Professor Kleber, Caroline Kleber from the Netherlands, conducted gene analysis for highly myopic patients, and she found a significant proportion of highly myopic patients had retinitis pigmentosa gene, and that is very interesting. And we have some pathologic myopia patients whose family suffers from retinitis pigmentosa. So we should maybe pay attention to the existence of retinitis pigmentosa career in highly myopic eyes, especially when myopia starts in very early in children.
That's very interesting to note, actually. And we know that retinitis pigmentosa is inherited in various forms, autosomal dominant, autosomal recessive, and obviously X-linked recessive is the one that we are most worried about because the prognosis is quite poor. So when you mentioned that thing about having this correlation with family members with retinitis pigmentosa and someone with high myopia, did they find that the inheritance of the retinitis pigmentosa in those families were of like the dominant type, the recessive type? Or?
Yeah, in some cases it's X-linked. So their male family members have a retinitis pigmentosa, and their female member with carrier of those genes show only phenotype of pathologic myopia without having retinitis pigmentosa.
Okay.
Yeah, but I think differentiating the retinitis pigmentosa children may be important when we think about therapy, maybe involving light to prevent myopia.
I see. And also, I guess, prognosis for them, right?
Yes, that's right. Yes.
Like we can counsel them. So we have one question from Professor Tam Yi-chong, who is our lead for optometry education at our InVision. So he's asking, for high myopia patients, should community optometrists also make it as a routine to perform OCT scans?
Yeah, I think that's important. OCT is, yes, I think so. I recommend that because OCT can measure the choroidal thickness, and based on OCT measures, we can maybe predict the outcome. So OCT should be done routinely.
Okay, so I suppose it's more of whether there's a budget for the OCT machine as well, but if possible, let's all have an OCT machine. And you say that if you were to do an OCT, you always want to do the EDI function for the choroidal thickness, right?
Yes.
Yeah. Okay. Good. Okay, Dr. Paul Chow, who is still a visiting consultant with us at NUH, he's asked this question. So for patients with myopic maculopathy, when would you consider surgery, and which patients would you manage conservatively? And is associated foveal detachment a definite indication for surgery? And then he mentions that is gas necessary or relieving the traction with IOM peel and vitreous detachment sufficient?
Yeah, thank you so much. If the patients have retinoschisis alone, we usually observe the patients. But when the height of retinoschisis is the same as high as the retinal thickness, in other words, when the retinal thickness becomes doubles, we consider surgery before causing foveal detachment. And if Once foveal detachment occurs, we immediately perform surgery, but once retinal detachment develops, the visual outcome is worse. So the best indication is when the height of retinoschisis is as high as the retina. And the gas, we don't actually usually inject gas unless macular hole develops during the surgery, because the gas is gradual release, gradual resolution of retinoschisis is better for fragile retina. So we usually don't inject gas.
So you say that instead of gas, you just do the ion peel, and that should be sufficient?
Yes. Yes,
Okay.
and also yes, leave the vitreous with the fluid only, no gas.
So I guess just to reiterate, you mentioned that schisis alone with not, and when it's grade 3 or 4, where that's the thickness, right?
Yes.
Then you would probably just observe. And if you have reached grade 3 or 4 before foveal detachment, you want to do some prophylactic surgery to prevent their visual deterioration. And definitely with foveal detachment, we would do surgery, but always counsel that the visual outcomes are usually worse.
Yes, that's right.
Okay.
Yes.
That's
Thank
great.
you.
Thank you.
Thank you.
So I think we are almost done. We're done with our Q&A segment. So thank you everyone for taking time off your busy schedules to attend our webinar today. For those who have been following our monthly Innovation and Precision Eye Health webinar series, our next webinar will take place in July. So stay tuned on our website for more details about the speaker and the topics. Have a great evening, everyone, and I hope to see you all again soon. And thank you once again to Professor Kyoko for educating us this evening with a wonderful talk.